First of all, I do want to acknowledge that I am attending here virtually from UBC, which is located on the ancestral, the unceded, the traditional, and the stolen lands of the Musqueam people. I'm thrilled to be representing the Edwin H.S. Leong Center for Healthy Aging, and we are proud from the center to be partnering to continue our partnership with Providence Healthcare to provide this dialogue on aging public presentation series. As you know, the Edwin H.S. Leong Center for Healthy Aging at UBC brings together researchers across disciplines to investigate aging in a comprehensive and holistic way in order to help people in British Columbia and across Canada and around the world to stay healthy, happy, and active as long as they age. Uh, it is very exciting for me to open up our final dialogue on aging public presentation of 2024. We are excited that for our final session, it is titled How Sensory Health Promotes Cognitive Health, within the theme for this past fall series of cognition, memory, and aging. We have two co-presenters, Dr. Kathy Pichora-Fuller and Dr. Walter Wittich. Kathy, I will first introduce Dr. Kathy Pichora-Fuller. She has her PhD and is Professor Emerita from Psychology at the University of Toronto and an adjunct professor in gerontology at Simon Fraser University. She was a faculty member in the School of Audiology and Speech Sciences at the University of British Columbia from 1992 to 2002. For over 3 decades, she has translated her research on auditory and cognitive aging to address the rehab needs or rehabilitative needs of older adults with age-related hearing and cognitive impairments. She received the Speech, Language, and Audiology Canada Eve Kasserer Lifetime Achievement Award in 2021 and the International Award of the American Academy of Audiology in 2014. In 2022, she became a Fellow of the Canadian Academy of Health Sciences, and she is the past president of the International Collegium of Rehab or Rehabilitative Audiologists and represents the International Society of Audiology on the World Health Organization World Rehab Alliance. Dr. Walter Wittich is associate professor in the School of Optometry at the Université de Montréal or University of Montreal, and is dedicated to researching the rehabilitation of older adults facing both vision and hearing loss. With a background in psychology, with a master's from Concordia University and a visual neuroscience with a PhD from McGill University, he further specialized in audiology during a postdoctoral fellowship at the Université de Montréal. Originally focused on age-related vision loss, he now explores dual sensory impairment and acquired deafblindness. His research spans basic sensory science, medical aspects, psychosocial factors, and rehab approaches to sensory loss. He holds the distinction of being the inaugural chair of Deafblind International Research Network. He's a fellow of the American Academy of Optometry and Quebec's first certified low vision therapist. And with that, I do want to thank both our speakers for presenting today. Have a great session. Thank you.
All right. Both Walter and I are clinicians as well as researchers. And we both have had lived experience with family members with dementia. So we have kind of a lot of different perspectives that we're going to try to put together. So it's a bit of a Humpty Dumpty, putting Humpty Dumpty back together again this afternoon. And we have many team members. So we have been part of the sensory cognitive team of this big group, the Canadian Consortium on Neurodegeneration and Aging. And so we are going to follow on Serge Gautier's talk last time. And he is also a researcher in CCNA. So that is a big family of researchers. And our cognitive member in the sensory cognitive team is Natalie Phillips. So there are many of us, and Walter and I are going to try to share some of what we've done. And Walter and I have both also worked on the sensory measures in the Canadian Longitudinal Study on Aging. So lots of good research. So let me just go ahead and give you the outline. So we are going to give a little bit of a context for why are there sensory cognitive links. And, by the way, the senses are part of the brain too. And you can't remember anything that you haven't sensed. So there's some pretty obvious reasons that we'll get into. We're going to talk a little bit about how the senses change with age. And then we're really going to try to get you thinking about what can you do to prevent sensory problems, to test or check out your sensory problems, and how to live successfully if you are having some sensory changes. And on that kind of, end of that outline, I'm going to draw to your attention that somewhere at the bottom of your screen, there's a little button you have that says CC. And if you haven't tried closed captioning when you're on Zoom, today might be the day to try it, because that is a beautiful technology that you can use if you're having trouble hearing. And it's used by many hard of hearing people. And Zoom is a fantastic technology for them because they can also lip read and see text and hear and plug in their devices. So Zoom is a great example of universal design that we can all use. Okay, so sensory cognitive links. And I'm just going to remind you about last month's talk. And what Dr. Gauthier talked about was a report from the Lancet Commission that provided a list of things that could be modified over the lifespan. And he went through all of these. He went through them touching on things you could do for each of them. So what Walter and I are going to do with you today is zero in on two of them. So hearing loss has been there since the beginning. It's one of the biggest contributors to the population's risk for dementia. And vision loss was added in the last version of this report in 2024. And even though we're going to focus on these two things, really, I think the story we're going to try to tell you is that these things do not exist in isolation. There are many interconnections. We're going to focus on the interconnections between hearing and vision loss because that's how we communicate. That's how we get around in the world, is through our senses. But the senses connect to cognition, and they also connect to many of these other risk factors. So we're going to kind of try to give you this sense of integration. So hearing loss, if we were looking at the whole population and we could wave a magic wand and nobody had hearing loss anymore, we might get rid of 7% of the world's risk of dementia. It's not quite the same story in Canada because we have different kinds of characteristics of our population's health. It's a little bit less in Canada than it would be in the world as a contributor. And it's the biggest one right now, tied with high LDL cholesterol. And then vision was added. And I'm going to let Walter talk a bit about vision and how did it get added, and hit what's near and dear to his heart is dual sensory loss.
So thank you you will see as Kathy and I sort of let this afternoon unfold, it's kind of very natural for us to go back and forth and have story time with Kathy and Walter. So I think there will be some of that today. When we have this discussion about vision and hearing, I always find it really interesting that it is easily intuitive that even what we do right here, right now, with people who are cognitively interested in the topic that we're covering, is that we do this, and that we can only do this because we assume that you have sufficient vision to see our slides and sufficient hearing to follow our communication. But it brings it home right away that this is only possible because our senses allow us this. And the moment you're interacting with individuals where there are problems, something simple as attending this webinar becomes a barrier. And then the link to cognitive decline, to cognitive withdrawal, if you want to, becomes very clear. When the first Lancet report came out, the vision community was very surprised because to our dismay at the time, vision was not included. We were a bit surprised because the people in the vision world would have thought that that should intuitively be in there. But the answer that we got from the commission at the time was that there was not enough suitable research that was published to actually be included in this large analysis of the global research literature. So the vision community sprang into action quite quickly and produced more and more focused and more usable work in order for vision to be included in the calculation of these modifiable risk factors. And so this year that bared the fruit of being included because it made sense. But what is interesting is that we do not have sufficient research at this point to actually propose that there is a separate amount of potential risk that would be linked to having the interaction of both vision and hearing impairment, given that most people that have some loss in one sense will use the other sense to compensate. And that is a very intuitive functional definition of dual sensory loss, is that when the second sense is impaired enough that it cannot help you with the loss in the first anymore. And then you are creating this unequal equation because 1 and 1 does not add to 2 anymore, but now you're creating something that is a bit larger than the initial pieces. But we know very, very little at this point about how vision and hearing loss interact in the context of cognition. There are some studies that tell us that they are correlated with each other, for example, but more so than if they were just independent. And like I said, the interaction of the two, we still have a lot of work to do in terms of cognition. Kathy.
Okay, so just this, we put vision and hearing together. So if you have a hearing loss, you might be a good lip reader and you're using facial cues to actually understand speech. If you're a blind person, you might use echolocation to actually understand whether there's a wall in front of you. So these are amazing abilities that we have, and sadly, some people lose them. So this fits into a World Health Organization guideline where they have thought about the integrated care of older people. So how do we put these pieces together? And they think that care for older people has to integrate some of these various changes with age that may happen in hearing, may happen in vision, may happen in cognition. And there's 3 other what they call key capacities that change. Mental health, like depression, mobility, think about falls and walking, driving, and malnutrition is in a category with of vitality, which also includes things like cardiovascular or metabolic issues like diabetes. So we want to integrate hearing and vision and cognition into this bigger picture of healthy aging, because getting older is complicated, and we want to do this to prevent declines, to address priorities as they come up, to do it in a person-centered way, and to optimize functioning. So you're going to hear that word functioning a lot this afternoon. There was a study done in France where people were coming to an Alzheimer's trial. So they were coming to a memory clinic, and they used the ICOPE guidelines for doing screening measures of these 6 key capacities. And lo and behold, even though people who were in their 70s and 80s primarily were in this memory clinic because of memory complaints, most of them, over half of them, had a hearing loss. And even had hearing loss than cognitive decline. And there was also some depression and changes in mobility and vision loss and changes in things like malnutrition. So those of you who are older, and I count myself in that group, you know how we need to kind of put all these pieces together. You go out of your house and you're going to hear some traffic, you're going to see what's going on, you're going to be walking or driving, you're using your mobility senses, and all of that gets put together by your brain. And then when you actually want to be active, maybe you're going for a walk with your friend crossing the street and you want to converse and you have to be safe crossing the street, and then you want to remember what your friend told you, what snippets of gossip there were, so you can go home and tell your family when the day is coming to a close. So everyday life, functioning in everyday life, how you go out there and live your life and stay active, has to rely on all of these pieces coming together, and the brain is the magician that makes it all happen. So in the words of an older woman with hearing loss, and if you've ever seen me talk, you have seen this slide because it just says everything. She says, when you're hard of hearing, you struggle to hear. When you struggle to hear, you get tired. When you get tired, you get frustrated. When you get frustrated, you get bored. When you get bored, you quit. And I think we would all agree that that is not what we want to happen. We don't want older adults to withdraw from social interaction and to become lonely. So we want to stay active, physically active, mentally active, socially active. And the senses are a gateway to maintaining that activity. And I put an eye in there. I'm pretty sure you could say the same thing about vision.
Yeah, I think that one of the things that's always worth saying again and again here is that we don't just use our vision for the things that are obvious vision. Like people will talk about, oh, I have trouble reading, maybe I have trouble recognizing faces, but there are so many other things that require vision that we don't necessarily think about. My example in the clinic that I really adore is that if I want to be able to hear you better, I should put my glasses on. Because audiovisual speech perception is a thing, right? And for anybody who has been wearing a mask during COVID, this is now more than clear how important it is for us to be able to see the face of the speaker in order to actually understand what they're saying. And you don't have to have a hearing impairment for that. That is relevant for everyone. So I think sometimes we just have to think more about the fact that vision and hearing actually link to every single activity that we do, because that's how we go through life. Kathy?
Yeah, so going back to that ICOPE idea of the WHO, this is I think Walter and I are very, very happy about this diagram. It's pretty simple. And basically, if you look at the red line, and kind of think about it going horizontally on the timeline, at the beginning, we can prevent conditions that happen during aging. And then when we go into the black box, we might need to address some of the declines that are showing up. And then at the right end of the box, we have some significant chronic conditions that begin to interfere a lot with how you function. But being rehabilitation professionals, we want to look at the blue line. So the blue line is what we could do. What can you do? What can we do as professionals? What can society do to keep people functioning and active and enjoying their life? So that's what we're going to kind of try to share this, like, how do we keep you functioning? I don't think we have any strong things that we can say that are going to prevent dementia or even slow dementia, but we can keep you functioning. So that is a very good thing for us to do. And how are we going to do that? In our rehabilitation toolkit, well, we could work with you. You could change some of your attitudes and behaviors. We could talk about some technologies, but we can also talk about the environment. So the key thing here is you have some abilities and you go out in the world, and sometimes the environments you encounter are a little bit challenging. So if you go to a restaurant, it might be noisy and then you can't hear, even though you could hear perfectly well in your living room. Or, you can't see so well if it's dark. Or, what's another example, Walter? A fierce environment. If we talked about mobility, you may be able to walk, but if you have to do a lot of stairs, it would be a problem.
Well, I
So
think
this functioning
yeah,
has to do with this interaction.
the first snow has fallen for us here in Montreal, and so suddenly mobility becomes a multitasking challenge because you have to avoid ice and snow, not fall off the edge of the sidewalk, right? There's a lot going on, so it's multi-processing suddenly.
Yes, and this term multitasking, that really kind of gets the brain's gears, in full operation. So you might change how you drive in that snow, and your brain is changing how it does cognition in adverse conditions. And to kind of change the gear on how the brain is dealing with these challenging conditions. Is going to possibly make people decide that it's too much and they're just not going to go out. They're just not going to go to the party. They're just not going to go to a meeting. And that's the withdrawal that we don't want to happen. So the easier we can make it, the more we can improve the environment as well as the person and how they cope with the environments, the better off we all are, and we can reduce some of that stress on the brain.
I actually
So
find it quite interesting, Kathy, when we talk about rehabilitation, we both often talk about how the person that is being rehabilitated is this active player in this process. Because it's very different than a medical model where you're given a pill and the pill will do what it do. But here, for you to make things easier, you actually have to work a bit harder. It's sort of it's counterintuitive because you have to put some effort into it for it to become easier. But it does pay back and does pay forward this way.
So it's a bit like practicing, when you start golfing, you don't hit the ball so well, and then you practice and you practice and you practice. And after a while, you become very good. And then you don't have to think about it some more. It becomes automatic. So that is the kind of the training aspect that rehabilitationists would be able to help you with. So you're out there, you're an older person. You know that hearing and vision change as you get older, but actually, these are really, really common impairments. They are the second and the third most common impairments. So it would be almost surprising if older adults did not have hearing and vision problems. We have the World Hearing Report, which has beautiful statistics about how hearing loss goes up with age. So the red bars in the top figure on the left, once you hit 50, you just see the bars climb. And you get to over 50% based on these world statistics by the time you are 85. Now that's for moderate hearing loss. But actually, the figure below it has a great big red ball for mild hearing loss. So there are many, many more people who have mild hearing loss So if we counted them, these bars would be even greater. Nevertheless, it usually takes people 10 or 20 years before they do anything about their hearing problems. And the average age of getting your first hearing aid is about 70 years. So there's a lot of delay that we could actually reduce. And if you've ever had a hearing test, you know, you have to listen to the tone and push a button or tell them that you heard it. And they give you this sort of a picture of your hearing called an audiogram. What I'm showing you here is the median threshold, the median audiogram for men and women at different ages. So if you're a 20-year-old, you can hear everything at 0 decibels. By the time you're a woman at 70 years or a man at 60 years, then you are having problems with these high frequency sounds. And that starts to affect speech perception. It starts to make you not hear little sounds like your microwave beeping, maybe. But there is a, let me see what this is. Yes, but everybody doesn't have the same age-related hearing loss. So even though losing these high frequencies is the very common result on this very common test, what most people detect first is lack of clarity, that the sounds are loud enough for them, but they're not clear, or they're good enough in quiet, but they really can't handle being in noise. And that is, I think, what happens in that 10 or 20 years. You notice some problems, but these aren't problems that you would measure in a hearing test. And I don't know how many of you have experienced this, but my neighbors are often telling me, oh, I went to have a hearing test and I think I have these problems, but they told me that it's not bad enough for a hearing aid and to go home. But that is not a good answer because there are lots of things you can do if you're having problems, because, you know, I still want you to be able to go to the pub with your friends, even though a hearing aid may not help you there.
So Kathy,
Walter,
we've had an interesting question in the chat that I think we can address right away. Even though we are presenting our slides the way they are right now, we can't actually make them any larger ourselves. There are some features in Zoom where you can manipulate the size of what is on your screen. However, one of the easiest solutions might be, and I'm sure, Kathy, you agree, we can give people access to our slides after the presentation. Do you think that that's a possibility, Kathy?
yeah, they're going to record this, so people will have the ability to see the recording, and I'm pretty sure Christine is happy to make other resources available.
Good. So in case you're having trouble because some of the text might be too small or the contrast is not too strong, there's always a possibility to get access a little bit later as well. So much like the WHO had created a world report on hearing, there's also a world report on vision that came out in 2019. Even though that's already 5 years ago, the information in there is still very much up to date. Turns out the biggest risk factor for developing trouble with vision is, of course, getting older. And so there are a couple of conditions that are specifically relevant to our context of Canada, but they are also global issues. Some of you may have heard of macular degeneration. So this is a slow, progressive retinal degeneration that specifically affects the central part of your vision. So this interferes with fine details such as reading, but also, for example, recognizing faces. Now, it is a very slow process, and for many people, this actually starts very late in life, and it is often the case that it progresses so slowly that people have passed away before it becomes a real severe problem. But, you know, that there's no guarantee. So age-related macular degeneration is definitely a concern. Linked to diabetes is, of course, diabetic retinopathy. But that can actually be quite nicely controlled if you are having ways to control your diabetes. it is another important factor why diabetes is, of course, worthwhile monitoring. And the third variable that is global but also a local issue is glaucoma. Now, glaucoma is basically linked to an increase of the pressure in the eye. It therefore threatens the optic nerve a little bit, and it will cause peripheral field loss. So whereas in macular degeneration, you have trouble in the center, with glaucoma, you have trouble in the periphery. And it may make you run into door frames or trip over furniture that you don't see that well in your periphery anymore. There's also, I think, Kathy, some animations on this slide just to highlight that these are the conditions.
Sorry.
That's all. It's
Sorry.
all good. No, it's fine. Just to point them out. There we go.
Okay, and I'm gonna just kind of, not to give you too much graphs, but if you don't worry if you can't see the details, because I'm going to give you the highlights. So these are findings from the Canadian Longitudinal Study on Aging. So we've done the world reports. Now we're going to take you to Canada. And if we look at Canadians, so red is women and blue is men, and we have a basic pattern of mild hearing loss rising. Moderate hearing loss is affecting less people. But if we look at the age where about half of Canadians have a measurable hearing loss, that would be around 75. And we can do the same thing for vision. And we have a similar finding. Things are getting worse as you get older, and by the time Canadians reach 75 years of age, half of them have a mild but measurable vision loss. So it's very common. So you are not alone if you're starting to notice these problems. And then this is where I think it's fascinating. If we look at who has a significant, even if mild, problem in both hearing and vision, by 85, you probably have a problem in both. And then I'm just going to keep going, Walter, unless you want to jump in here.
Oh, no, that's all good.
And then, we have other things we can measure, like balance, which is another sense. How long can you stand on one foot? Those of you who take Tai Chi probably know that this is something you can practice and get better at. But the number of impairments you have also goes up as you get older. So you can have 1 impairment, 2 impairments, 3 impairments. You can collect the full deck of impairments. And the older you are, the more likely you are to have multiple ones. One of our colleagues, Don Guthrie, worked with us on data collected in Ontario in home care and long-term care settings. So these are hundreds of thousands of people in these settings. And the green area is if you only have vision or hearing or cognitive loss. The blue is if you have a combination of 2, and the pink is if you have a combination of 3. So, these combinations keep stacking up, and we really have to deal with them together. So what we did in our CLSA work was look at, okay, if you have only hearing loss or only vision loss or only poor balance, that is related to your general health and also to these cognitive measures of memory and executive function. But if you have 2, the orange bars, there's even a stronger connection. And if you have problems in 3 of the areas, they're the most strong connections. So I think you kind of see where we're going here, that we have to see the whole picture of a person. Now I'm going to just give you a little bit of a story here about people who have good hearing and good vision and good cognition, who are younger and older, and this is a very well-known study of memory. And what is done in the experiment is just changing the volume dial. So 65 decibels at the bottom is louder than 45 decibels. 45 decibels is about the average conversational level of loudness. And if you change the dial, the volume dial, young people start to remember a bit less when it's quieter, but they're still pretty good. Older people, as you turn down the dial and make it quieter and a little bit harder to hear, they remember less. So this has got nothing to do with dementia. This is true for people who are perfectly normal, that if you make it harder, this is basically changing that environment, making that environment less accessible to you, then you're not going to be able to remember it. Your brain is going to work harder to get the signal, and it's going to run out of the ability to store it in memory as well as it could if the signal was good. So this is a general finding that has happened in the many times. But I don't know. Do you want to speak to this one, Walter?
Sure. So what you can see in the figure, what the figure on the left side is trying to tell, is you're looking at a composite score of multiple measures of memory. And up in this case is good. As you can see, we're going across on the bottom axis, on the x-axis, to higher levels of decibel hearing levels. So these are numbers where basically as you're going over to the right, there's more hearing impairment present. And what this basically tells us is that in individuals that have higher levels of measurable hearing loss on their audiogram in this case, they are more likely to have lower scores on their composite memory testing. The way this translates is that if we would, for example, compare two participants that we have sort of artificially created here, Sally and Joan, they are comparable on all other things. They are the same sex, they have the same level of education, they're otherwise very similar in their health status. Now, Joan has a moderate hearing loss on top of this. So that's the big difference. Sally and Joan are pretty much comparable, only Joan has a hearing loss. And when we now compare Joan to Sally on these performance measures of memory, then she performs as if she were about 5 years older, even though they're comparable on everything else. And she would appear as if her cognition is the person of 8.5 or almost 9 years older if she also would present with a mild vision loss. So you can see how the addition of these sensory impairments then are measurable and observable in the cognition score of our participants.
So the moral of the story here is if you're going to go to the clinic to be evaluated to see how your memory is, you better make sure you take your glasses and your hearing aids.
Yeah.
And the professionals have to understand that this is important. So they're all tied together, and you don't want to put yourself at a disadvantage. You want to give yourself the best signal in the auditory domain and the visual domain. The better the signal, the better your brain will do things like remember what you heard. We have also, with our CCNA team colleagues, looked at CLSA data to see how different sensory losses, alone or in combination, affect your social networks and participation, your social support, and your loneliness. And what's underlined in red basically just says, yes, it matters. So people who have sensory losses are disadvantaged in terms of how much they can remember, but they also have social consequences to these losses. And that is something that we need to be more tuned into. It doesn't necessarily mean that the sensory losses cause these problems, but they aggravate the problems. And why should we be um, subjecting people to problems that we could do something about? It is even the case, this is some of our work again with our colleague Don Guthrie, looking at the contributions of hearing and cognitive impairments combined, resulting in more long-term care admissions, which another thing we want to avoid. Okay, so sensory aging is a big deal, and it's part of cognition in your everyday life, and it could have serious implications to how you get looked after in the healthcare system. So what can you do? So Walter, how can we prevent hearing loss?
So the standard sentence that we always use in the clinic is eat well, sleep well, and stay out of the sun. The stay out of the sun piece is potentially the most intuitive. Sunglasses are also a fashion piece. So I encourage you to choose a fun, cool, comfortable pair of sunglasses that are simply your partner in crime in your day as you go out into the world. Protecting yourself against UV light is important, especially earlier in life and in midlife to prevent damage later on in late life. But it also turns out that as we get older, there are situations where glare is more troublesome. And so aside from your UV light protection, you also get a protection for glare, which will in many cases make life easier. If you're still driving, that is obvious probably because that is one of the situations when we encounter a lot of glare potentially. Now, what else did I put here? Yes, now, but I usually deal in visual impairment, but the thing is that there are also other things that make vision simply difficult at times. And I think the most common would be that people experience dry eyes as they get older. Some of that has to do a little bit with anatomy and physiology. It's simply the eye will dry out easy as we get older, but there is something that I quite enjoy, which is the 20-20-20 rule. So if you're somebody like me who spends a lot of time reading, or if you enjoy watching television for a while, focus on something that is at least 20 feet away from you for about 20 seconds and do this every 20 minutes. It has an interesting side effect. When we focus on something, when we get engaged or fascinated and interested, our blink rate slows down. It turns out we blink less when we're interested. That is one of the major reasons why people will experience fatigue in their eyes, and that's often linked to dry eyes. Right now, Montreal in the winter, where I am, life without a humidifier is tricky. I always encourage people to have a humidifier if it's not in their bedroom, but at least in the space where they spend most of their time, because that will also make a big difference. And it also can come back to those sunglasses you have chosen, because sunglasses sometimes have a protection that is on the side of your temple that will protect your eyes from wind outdoors. And if dry eyes is an issue for you, then wraparound sunglasses could be an excellent choice for you. There are various people out there in the world that will want to sell you various supplements about things, and some of these are, of course, also possible for protecting your eyes and your vision. Sometimes people simply are after your money, but sometimes there are actually things that can be useful for you. So I would always recommend to consult with an optometrist before you engage in getting specific supplements that are intended to protect your eyes. But for those of you who are preventing macular degeneration, there are actually some supplements that have been shown to be beneficial. Let's see, what else did I put on our slide here, Kathy? Did I add something?
I think it's going to me next.
Yes, go ahead.
All right, so I think nobody would be surprised that noise is a bad thing. Noise damages your hearing. And once it is damaged, it does not come back. So there is no way the sensory cells, once they're lost because they have been damaged by noise, it becomes permanent. So you cannot bring that back. So the noise could be at work. It could be in your hobbies, people that do carpentry. It could be because you like listening to your portable audio device. So the point at which noise becomes dangerous, you kind of multiply how loud is it by how long is it. So if you really like listening to loud music, that's okay, but just don't do it very long. Okay, so kind of dose yourself so you don't listen to your portable audio device 10 hours a day at high volume. That would be a very bad thing. And if you are going into these adverse environments that are noisy, you can wear earplugs or earmuffs. Some fancy headsets have noise cancellation that you might like to wear if you're in an airplane, for example. Some of the other things that you might not be aware of is that there are a lot of drugs that are poisonous, ototoxic to your ear. And actually, one of the most common ones is aspirin. So, very, very high levels of aspirin taken for a very long time, which some people with arthritis might do, that can actually um, create some hearing loss. So, there is a whole area of testing hearing if you are having cancer treatments and you are taking ototoxic drugs and you do want to cure your cancer, but you don't want to have a hearing loss. So figuring out which medications and which doses, these are important things to do. If you like traveling and you're going to South America and you want to take anti-malarial drugs, those also are very ototoxic. But if you get the right prescription with the right dose, you can be safe. So something to think about. One of the signs, if you are damaging your ears either by noise or by drugs, will be that you might hear ringing in your ears. And sometimes I say, well, that tinnitus or ringing in your ears is kind of the death knell of the auditory hair cells. So if you get tinnitus, that may be a sign that you're doing something that is destroying your hearing. So Walter and I have talked about, how to prevent vision and hearing loss, but we also kind of have this combined story. You heard a lot about this from Dr. Gauthier about the importance of nutrition and diet, good diets, and exercise you've heard about. Well, as luck would have it, um, nutrition and exercise are good for your health in general, and they are going to help you to control your cardiovascular issues, hypertension, and heart disease and diabetes. Smoking is another generally bad behavior for your health. And I put noise in there again. Pollution was on the list that Serge Gauthier talked to you about. So the good news is if you're doing these health promoting behaviors which are good for all of aging, they actually help your eyes and your ears. So keep doing those good things because it's good for your brain, but they're also good for your senses. And then in turn, so some common causes create brain issues as well as sensory issues. But if you have sensory issues, that in turn can have repercussions for your physical health, your psychological health, and your social health. So if we look back at that picture, that little reminder I have up in the corner there, many of the things on that Lancet list include things which are related as causes or consequences of sensory loss. So it's all connected. About testing. Okay, should you have your hearing tested and how do you do that? Well, these days with technology, you can do it yourself, which is fine. You can ask your doctor. You can um, have different ways you can access this. But I would say these days, I kind of, as an older person, I would take advantage of some of the free do-it-yourself tests. The World Health Organization recommends for hearing that auditory screening, hearing screening starts at the age of 50, and you should do it once every 5 years until you're 64. And then from 65 on, you should check your hearing once every 1 to 3 years or whenever you notice a change. And often this can happen when you have regular health checkups. So, what about vision, Walter?
Yeah, I was just thinking about, the idea of doing something regularly. There are some things in my life, like for example, every December I have to change my winter tires. Now, it turns out that is a great reminder for me to check the batteries in my fire alarm in the kitchen. And I also use it as a reminder to do other things. So I wonder if this would be something that people would want to potentially add to their annual list of the things you only do once a year. And one of those could be to have your senses checked. This way it kind of becomes part of an annual routine. I think especially after age 65, it's a good idea to have a comprehensive eye exam once a year. It is specifically often interesting when we're dealing with diabetes. This does not mean that your eye exam becomes more important. I actually find it interesting that in many cases, diabetes is diagnosed in the eye before it becomes apparent somewhere else. And so even if you think you're in good shape or if things holding up quite well, an eye exam is a good way of confirming that. So I usually recommend that once a year after age 65 is a good place to start.
Okay, so what would you do if you wanted to do it yourself, Walter?
So the Who Eyes app, all you really need is a smartphone. You can download this app through the website of the WHO. The QR code is on the screen here. So if you're accessing our slides later on, you can simply use that to access it directly. It's a free app that installs itself on your phone, and then it gives you specific instructions on what to do and how far to hold it away from your eyes. That is actually an important piece because, of course, if something is very tiny, you will be able to see it better if you bring your phone closer, but that's not really the point here. You want to make sure that you're doing this always at the same distance. And the task is very simple because basically it will show you what we call the tumbling E. You see on the bottom right side here, we have the letter E facing up, down, left, right. And so you basically will be facing different letter E's, facing different ways, and you swipe on your screen in the direction that the fingers of the E are pointing. And if you get it right, then the little symbol will become smaller. And if you get it wrong, it will become larger again. And this way it will find a threshold at which size you are able to correctly tell which way this letter is facing. And that can be converted into your acuity. And the machine will then be able to tell you whether for your age that this is falling into a range that is acceptable as normal. It also has a couple of recommendations of healthy vision behavior and where to go and what to do in case you would like to consult with a professional.
And the World Health Organization has a similar way you can test your own hearing, and it's called Hear Who. So if you just Google Hear Who, you will find it easily on the internet. It's free. You can test your hearing on a number of sites, but sometimes they're going to lure you to people who want to sell you a hearing aid. But I think, for me personally, I trust the WHO. and you can find your own results. It will make you check if the noise level is okay for you to test your hearing. And it uses just a sequence of numbers that you repeat, like 3, 9, 8 in background noise, and it adjusts the level to find out where you can repeat those words correctly, what level and what amount of background noise. And it will give you some information. And you can share these results with your health provider. You can say, well, you tested yourself and it said you had a problem, so now you're seeking some help. So this is, for those of you who are listening who are health professionals, this is also something you can just do. It takes, less than a couple of minutes, and it's a very handy screening test. So if you have an iPhone, you can test your hearing, you can test your vision. And testing it as opposed to, just you can ask people, do they have difficulties hearing, but testing them adds information. So many people don't actually realize that they have problems unless they get a test result. And that test result, people who would fail the test, but who don't think, they haven't acknowledged that they have problems or they haven't done anything about it, those people can have lower cognitive scores and more social isolation. So you may not think you have a problem, but you can actually decide if you want to have a test. You can check that out. And many people don't know that they've started to have a hearing problem, and then one day they get a hearing aid and it's like, oh, my microwave makes a sound. I never knew that. So the things that you miss, you don't necessarily know.
Just as a side comment, I do see that there are some comments and requests in our in the chat that we will come back to, so don't feel desperate. We will return to your requests.
All right. And by the way, the recent recommendations by Canadian geriatricians is that hearing should be screened as part of a dementia workup for all the reasons we've just said. And one day they'll have vision in there too, Walter. But this should be becoming more common in clinical encounters, whether it's about your diabetes or possibly during a dementia workup. So who are these sensory professionals? You can test yourself. You probably know about medical professionals, so otolaryngologists or ENTs for hearing, or ophthalmologists for vision. Those are medical doctors, and they may do surgeries, and they may do checking out, of problems which you may be having, which are not due to simply aging, things that have medical or surgical corrections. The people who are regulated health professionals in BC, you would see an audiologist to have diagnostic testing done, or an optometrist to have testing of your vision done. And then if you need rehabilitation, definitely audiologists would provide that as the regulated health profession in BC. And Walter, do you know, are vision rehabilitationists, are they, I know things vary across provinces, but would people in BC find one?
Yeah, no, what I would usually recommend is that if you're somebody who is eligible for vision rehabilitation, then your optometrist will be able to where to send you near to where you are, because sometimes these people are not that easily identified because they're not that many, but they do exist, and usually an optometrist will know where to go.
And then there's another level of professional, which is more focused on technologies. So hearing instrument practitioners, they could fit you with a hearing aid, or opticians could fit you with glasses. But that is part of, but not as extensive as other rehabilitation. And for people who have both, if you have a 90-year-old who's become effectively deafblind, what could they do, Walter? Who would they see?
So in Ontario, for example, there is a special profession, the interveners, that are trained specifically as facilitators for people that live with both difficulties in vision and in hearing. Like I said earlier, oftentimes one is not available anymore for the other to compensate in terms of the sensory loss. And so people that complete the interveners program in Ontario are available to help. Now, what I find really wonderful about this profession is that these are people that will do things with you, not for you, right? So these are not people that are supposed to replace your ability to do things, but they are there to specifically assist with accomplishing things that people want to do. You want to go grocery shopping? You may need help here or there to cross the street safely, but otherwise you're fine walking. You may need help to identify price tags, but otherwise you're fine in the store to find your way around and choose what you want. You may need help when you're in the process of paying to make sure that this is all good and right, but otherwise you're good packing your bags and going to where you need to go. And so interveners are basically there to assist with the pieces that require assistance. But like I said, they're doing them with you, not for you.
All right, so we have, I'm going to try to finish in about 5 minutes, and then we have about a half an hour left altogether. So I hope we will have lots of time for questions. So rehabilitation is what we would love more older people to take advantage of if they need some professional help. And I like this definition of health, that, we know things change as people get older, but it is how do they adapt to, respond to, and control these challenges and changes that is what helps them to keep functioning, to keep up to that blue line. And working with people in rehabilitation is really important. And don't be afraid to do it. It's hard to find rehabilitation professionals sometimes, but they're out there and they would love to help you. And really, this is about helping you to understand how to change your environment or use technologies or change your behavior so that you can do and be what you value, which is the ultimate goal of healthy aging in this decade of healthy aging. So you've had your screening test, you found some professionals. Walter's given you a few ideas about, what are they going to do to you? How can you do that attitude, behavior, technology, environment? How can you do the changes that'll help you to adapt and keep functioning? Well, I am here to tell you in a very clear voice that if you have a hearing loss, it may be useful to get a hearing aid, but that is not the whole story. And the best study that has happened, that the results were released for about a year ago, this ACHIEVE trial, where it was a randomized control trial, and they had a group who got hearing aids and a control group who got a health information intervention instead. And over 3 years, there was absolutely no significant difference in the change in cognition between the group who got the hearing rehab and who didn't. But the good news is there was plenty of evidence that the group that got the rehab had many benefits to communication. So we don't know, what would happen over a longer time frame. But I'm really concerned that there's a lot of misinformation in the media about get a hearing aid and you won't get dementia, and there is no scientific evidence to back that up. But it doesn't mean it isn't a good idea to get a hearing aid if you're having trouble communicating. So let's just clear the air there. Walter and I and some of our colleagues wrote a little paper, which I think is fairly easy to read, for the World Alzheimer's Report on how does sensory fit into functioning with dementia. And we have what we keep saying, you can change attitudes, behaviors, environments, technology, but also we can change at the level of the individual, of the professional, and of society. So we're going to just kind of take you through a few things. You know, what can you as individuals do? And I'll let Walter do this slide.
Yeah, so this is sort of, these are pieces of advice that I give in a clinical environment, but also when I'm teaching, but also, with friends and family. It turns out, Kathy has often reminded me that if you yell at somebody because they need more volume, this will be just as uncomfortable to them as it is uncomfortable to you. People can still experience pain when something is too loud, even when they have a hearing loss. And so simply yelling at somebody will not necessarily improve their ability to comprehend what is being said. So it is really more speaking clearly. We've earlier mentioned, the importance of actually being able to see the face. And so hearing can be supplemented through vision. Try to avoid yelling at people. It's not really useful for anybody involved. But one interesting piece that can facilitate hearing and comprehension is context. And so if people know already what it is we're talking about, then they have a better idea of what vocabulary is going to be used. And so suddenly some of this ambiguity of what somebody might say disappears. So if we're knowing we're talking about yesterday's trip to the mall, then already we know what happened, who was present, and where the storyline might go. So giving context is important. In a clinical context, what I find very important for me as a service provider is that if there is information where I need to make sure, did that make it in and did it get processed, then I asked people to repeat the information back to me. This does not have to be a clinical context, but if you're asking for somebody's phone number, if you're giving your phone number to make sure that what they heard is actually what you said. When we're looking at vision, glare is an interesting one because we often forget about this. If you're sitting in your favorite kitchen chair and the person across you has the window behind them and the sun comes through the window, chances are there are going to be shadows, there is going to be glare around the person, and suddenly you can't hear them anymore because you can't get any facial cues anymore. Glare is an important thing to avoid, can make visibility and audibility a lot easier. Whenever you have situations where you can make things larger, that will help. It turns out you don't need to be visually impaired for that. I have my telephone settings on a larger font because I simply find it easier. So large print is a good idea. It often can fix many problems. And it also turns out that large print together with good lighting is often all you need. So having a good lamp in your life that has daylight level white light, that is something that is useful to explore. If you're at a store or if you're going through purchases on Amazon, check whether the lighting levels are similar to what we call white light or daylight. You want to avoid noise. Kathy has already talked a bit about noise earlier. For the clinicians among you or for the loving family members, one of the things that I think is often very expensive but extremely useful is to give people more time. If you have a family member who has combined vision and hearing loss, you already know that things happen slower because there's more effort involved in processing things. So the moment you don't rush somebody and you give them the time that they need, chances are things are going to go that much better. If you are in a situation where you're actually administrating tests, whether these are screening tests or evaluations or professional assessments, I generally recommend to use tests that do not have timed items. Sometimes we will say, in the next minute, tell me so and so many words that start with the letter F. the time pressure itself takes on a new dimension when you're dealing with somebody with sensory loss, because it will create stress that is not necessary. And of course, together with magnification, I'm a big friend of ye old magnifier, but it also turns out that many of our telephones have wonderful magnification apps and accessibility features. We actually published an article a little while ago that for many people now, their smartphone replaces many of the more traditional accessibility devices because of the features that are built in, and because there's no stigma attached to using a telephone in public, which of course is sometimes a bit tricky when you're using a device that is specifically made for an impairment. So telephone holds a lot of solutions for you, and I encourage you to explore them.
All right, I'm just going to say there are so many things professionals can do, so in hearing clinics and vision clinics, we have to understand people can have dementia, they can have mobility issues, and vice versa. So we really need to push on this integrated professional care, and there are lots of ways we can make experiences in healthcare settings better. Walter's been involved in an international exercise to create recommendations for interprofessional team practices. So there is lots that is new and happening there. I know Dr. Samir Sinha talked to this group many times, and he was the leader of the reform of the long-term care standards in Canada. And we contributed information about access to communication for residents who have sensory and cognitive impairments, and many of our recommendations were implemented. So at the policy governmental level, that's an example of what we're trying to do. In the province of BC, there is new accessibility legislation that the province is taking very seriously, and hearing and vision can be produced in the community to a greater extent now that we have this kind of governmental support. I live on Bowen Island. We are about to have the opening of a new community center, and our accessibility committee for our municipality, has been able to advise on, well, what are the architectural environmental features that will make this place sensory dementia friendly? What kinds of technology? How should the staff and the users be trained? And how can we make life outside of the clinic, where people are going to go and function and be active, how can we make that succeed? And there are some fabulous new technologies. This one I'll just mention in case you want to look it up, called Auracast, which will enable people with hearing loss to do amazing things, whether they have a hearing aid or not. It can be used with smartphones, again, as Walter said. So if you're going to the theater, or you're going to a lecture, or you're going to meetings, you're going to an airport, those are places where hearing aids don't often work, but there are complementary technologies which are, very recent and very exciting. So we are very excited about how much we can do to help people function better with their senses. And now we should really turn to the questions. So I'm going to stop sharing there.
Mm-hmm. I've taken a couple of notes as we went along. There are 3 items that are easily solvable. There was a question about accessing the Hear Who and the Who Eyes. I have put the actual web links for the WHO websites where you can find the apps as well as some information about them. So this way we don't need to go back to the QR codes, but you can also just search them in the App Store itself, and they will pop up if you type in Who Eyes or Hear Who. There was a question earlier about which supplements I was referring to. So I am always very careful when I talk about nutrition and supplements in general, because I don't know what you're eating. I don't know where you are, and I don't know exactly what your habits are, which is why I think nutrition is an important topic to consider when you talk to your healthcare professionals. There are antioxidants out there are vitamins out there are mineral supplements out there, each of which may fit a very specific situation of somebody's condition and nutrition. So I'm not going to go deeper into what's good or what's bad, because what that may or may not be will very much depend on your personal profile and your needs. But basically, I'm talking about antioxidants, vitamins, and minerals that are often mentioned in the context of sensory loss.
There really is a literature on, the healthy diets that you would have recommended to you. There's a CCNA healthy diet for dementia. For example, there are many healthy diets, but those actually, if you are a person who sticks to those healthy diets in general, that will reduce your risk of hearing loss and tinnitus.
Another item that we have here, there's a question from Graham. What architectural aspects can facilitate better sensory reception? This is a good one, because what's good for one sense is not always good for the other sense. But yes, Kathy, you've looked quite a bit into environmental
Yeah. So I would say Walter and I have prepared a module for Brain Health Pro, which is a product of the CCNA. And we use this behavior technology environment trio to work through solutions that people can learn about. And in the environment section, so we can share that if people want to follow up with us. But, for acoustics, you don't want to have a lot of echoes. So you want to have wall materials, ceiling materials, floor materials that are going to absorb. On the other hand, you don't want to feel like you're underwater. So you need to have also the enough echoes that you can get sound across a large room. So if you go into a theater, in Vancouver, if you go to the Chan Center at UBC, you'll see the walls are designed so that they produce enough echo, but not too much. And you can also achieve some of that through interior design. What kind of furniture do you put in? So that's kind of a quick answer, but mostly about echo is it echo and noise are things that can be controlled very well acoustically.
The
So
parallel
Walter,
the parallel version for me often is glare and lighting. You do want light, but you don't want too much light, and you want the light to come from the right direction. So this also makes it difficult to really give advice, because different people prefer different things. I will give you an example that is that's potentially intuitive, where you cannot make anybody happy. Flooring. If you have a very shiny and hard floor, it will, for example, be easy to clean by the staff that works there. If it is shiny, it will reflect light, and so it makes it potentially visibly more difficult. But if you are somebody who may really depend on a flat and even surface, wearing a hard shoe to have a better sense of balance, then such a floor is ideal. The last thing that you want is carpet, but then carpet might absorb some of the noise. So you can see how different features will work for some, but not for all. And so there's not really one size that fits everybody.
color is another thing, Walter. I think, that contrast, maybe you want to say something about contrast.
Yeah, so my favorite, especially here in Montreal, for example, we will have stairs that go down to the subway system. There's a big yellow stripe at the top stair, and then there's a really beautiful yellow stripe at the bottom stair. And all that really does, it just shows you where you will start falling and where you will stop falling. But what we really would need is to have contrast on every single staircase. I've been in hotels that have beautifully creative patterns on their carpets, and you therefore can't see any steps or anything that's uneven at all. Color is an interesting one because you can use color really to identify important features of the environment that make it very easy to find the elevator, for example. Contrast may potentially be even more important than color. The example I often use for poor contrast is if you're walking on the sidewalk underneath trees in a construction area, it becomes difficult to know whether something is a hole or step or a shadow. And so, especially if you have early losses or changes in vision, then contrast becomes a difficult task. So you need to be careful. This is also where I, once in a while recommend to have a decorative cane that you may use for walking, but it could be useful once in a while to poke into something to see whether it's a gap, a hole, or a step. And it will make life potentially easier.
Are you watching?
Yes, I'm just looking here right now. Abigail writes to us, I was cutting an apple. Suddenly I noticed my middle finger is bleeding. I didn't feel the pain. Would you say it might be related to sensory issues? So it turns out as we get older, we don't feel pain as much as we did when we were younger. We do lose a little bit of sensitivity things. In terms of vision, for example, if any of you had an easy time putting your contact lenses in when you were younger, and then that becomes a little trickier as you get older. And also the surface of the eye is a little bit less sensitive as we get older. The surface of the fingers might have a tiny bit of neuropathy simply because you've gotten older. I am now in the second half of my 50s, and so I'm starting to discover how things starts breaking. It's a fascinating experience how you notice how stuff is changing. I wake up once in a while and I see a bruise on my arm and I'm going, what did I run into this time, right? But I didn't even remember it when it happened. So I think that this is quite normal, that we're not that sensitive to things anymore as we get older. We just have to monitor better.
So there are other senses which we are also studying, but not to the same extent yet. So smell is a very important sense that is also a predictor of dementia. And touch in dexterity, like, I can give you a small hearing aid, but what good is that going to do if you can't see it and you can't manipulate it? So lots of senses at play. So one of the things our research is about now is the extent to which these senses have a common root or different roots in relation to cognition.
But I also
will say about apples, about eating, you want to enjoy eating. Nutrition is important, and nutrition can affect hearing, but hearing can affect nutrition. So once I went to a meeting with people in the Faculty of Agriculture at UBC, and they have a course on the senses. And it's like, why do you have a course on the senses in agriculture? And they just looked at me and they said, well, it's not an apple unless it crunches.
Mm-hmm.
So many of our pleasures, there's the necessities, but there's pleasures. And so we are possibly need to think about this, if we're designing meals for people.
What, for example, also changes as we get older is our sense of taste and therefore flavor. People will increase themselves how much salt they're adding to food simply because they're not tasting it the way they used to, and may then go too far and consume too much salt, which will have other potentially tricky effects in health. So it always becomes this balancing effect of what do I need, what do I want, and what is the best way to manage that gray zone in between. Coming back to a question that we had earlier on, I just remembered now as well. We got a question about our slide, Kathy, about the percentages of the risk factors. And so one of the questions from Laurie was, if you have multiple risk factors, does that increase your percentages? So we may have to say a word or two about those famous percentages, because these percentages are created at the level of a population, of a country, of a continent. And so they are not actually designed to be translated into, if you have a hearing loss, you can reduce your risk by 5%. That's actually not how this number works. Kathy, do you want to say 3 things about the population fraction?
Well, I think also when they do those calculations, if you are into this, I don't know if you're a scientist or if this is something that you would like to do, but those Lancet papers are free online, and they calculate something called commonality, which sort of takes into consideration the extent to which some factors are intersecting. There's some really interesting papers done by Canadian researchers on what that looks like in Canada. So I think Serge may have mentioned this, that in Canada, lack of physical activity and obesity, are the really important ones. But they're connected to hearing loss. So I think you can't play a game with, well, I'll do this risk factor, but not that one.
Yeah.
They all come together. So I think if you're doing well on your diet and your exercise, check out your census. That's, I think, the message we want to give here. And in the end, what counts is, how does it affect your everyday activities? And what is it that you want to do, and what do you value? Who do you want to be? What do you want to do? And how can you do that better?
I actually like this idea, let's say the thing that you should really do, or the thing you really would want to do, is to go for walks more often, or you want to be physically more engaged somehow, or to do a certain activity again, could even be a hobby. What is it that is actually keeping you from doing this? Is that because you haven't slept well? Then maybe your risk factor could actually be related to sleeping. Is it because you don't see that well anymore, and so you're a little bit afraid of going out? And also, these things hang together. Turns out life is complicated. So once in a while, you have to think about 3 things to get to the 4th one. But it does work. So it will, because overcoming these sensory barriers is not just a solution to one thing. It'll be a solution to many things at the same time.
I noticed in the chat, one of my colleagues, Dr. Lisa Dillon-Edgett, who's an audiologist who runs a course in Vancouver at Vancouver Community College. And her course is an online course or an in-person course. It's called Living Successfully with Hearing Loss. And basically, that would be a kind of way you could meet with other people in a group, and you could discuss, I wish I could, well, Walter, we'll just switch to vision for a minute. You told me about, there's a curling club in Montreal where blind people curl. So if you really want to curl and you have a vision problem, you can do it, but you have to kind of discover how to find the right environment where you can do that. So discovering your behaviors, your environment, your technologies, there are solutions to most problems, but Start with your problem, and then we'll work to find some solutions.